Good morning, everyone. I am Chandrika, Senior Resident, Department of Radio Diagnosis, AIMS BB Today we'll discuss few interesting X-ray cases. Case 1. 9-year male came with complaints of snoring associated with mouth breathing. Referred from ENT department for lateral radiograph of skull and neck. Lateral radiograph of skull showing well-defined soft tissue density in the posterior aspect of nasopharynx, causing luminal narrowing of nasopharyngeal airway. Rest of the skull and cervical spine appears normal. Diagnosis was given as adenoid hypertrophy grade 3. Adenoid is said to be hypertrophied if it is more than 12 mm in AP diameter. To measure adenoids, draw a line parallel to the base of the skull and measure the adenoid at perpendicular level to the first line. Measure the palatal airway between adenoid and palate. Coming to the grading of adenoid hypertrophy based on residual palatal airway. Grade 1 if it is more than or equal to 6 mm, grade 2 is 3 to 6 mm, grade 3 is less than 3 mm. Coming to visual grading of adenoid hypertrophy, grade 1 is one-third filling of nasopharyngeal airway, grade 2 is two-third filling, grade 3 is two-third to near complete obstruction, grade 4 is complete obstruction of airway. Grades 3 and 4 are indications of surgery. Coming to case 2, 43-year female with complaints of shortness of breath on exertion and non-radiating chest pain, referred from general medicine department for chest radiograph. Frontal radiograph of chest shows rotation to the left, trachea and major airways are normal, prominent bronchovascular markings in bilateral lung fields with upper lobe venous diversion, prominent bilateral hyla, curly B lines in right lower zone, cardiomegaly, enlarged pulmonary bay, homogeneous opacity in right lower lung field, likely because of cardiac overlap. Bilateral cardiophrenic and costophrenic angles are normal. Bilateral hemidiaphragmatic contour is maintained. Visualized bones appear normal. Based on the radiographic findings, diagnosis was given as pulmonary hypertension with cardiogenic pulmonary edema. Coming to key findings of pulmonary hypertension, we find enlarged pulmonary bay, enlarged pulmonary arteries with peripheral pruning of vessels. Coming to the findings of pulmonary edema, prominent interstitial markings or septal thickening in interstitial type, airspace opacity seen in alveolar type, curly B lines, cephalization that is upper lobe venous diversion, and cardiomegaly if cardiogenic cause is seen. Coming to case 3, 16-year male postoperative case of Hirschsprung disease. POD3 referred from pediatric surgery for radiograph of erect abdomen. Erect abdomen radiograph taken on POD3 shows nasogastric tube in situ, multiple dilated small bowel loops with air fluid levels noted predominantly in the central abdomen and left hypochondriac region, air under bilateral hemidiaphragm with partial air in pelvis indicating air in large bowel, radiodensity in right paraumbilical region and iliac region corresponding to colostomy site. Serial radiograph taken 2 days apart shows reduction in size of small bowel loop dilatation with reduced air fluid levels and increased air in large bowel, and also significant reduction in air under bilateral hemidiaphragm. Radiograph findings are suggestive of postoperative paralytic ileus with partial or low-grade small bowel obstruction with pneumoperitoneum. Postoperative ileus is a common finding. However, normal recovery times are as follows. Small intestine, it is 0 to 24 hours. For stomach, it is 24 to 48 hours. For colon, it is 48 to 72 hours. If more than 72 hours has passed, it is termed as paralytic ileus. Coming to case 4, 52-year male with history of trauma to the right thigh 8 years ago. Reduction of fracture was done, no details were available. Now complaints of pain and swelling at the site of old fracture with normal range of movements. Referred from orthopedic department for knee radiograph. A radiograph of right knee AP and lateral view shows malunion of fracture of distal shaft of femur with osseous hypertrophy, generalized decrease in bone density with reduced medial tibiofemoral joint space and marginal osteophytes, suggestive of grade 3 osteoarthritis. Diagnosis based on radiographic findings were given as malunion of distal shaft of femur fracture. Coming to case 5, 19-year female with history of corrosive ingestion 2 weeks ago, treated elsewhere, came for follow-up. Referred from general medicine department for chest radiograph. Frontal radiograph of chest shows no rotation, major airways are normal, inhomogeneous opacity in right lower lung field and right perihilar region. Left hilum is normal. Costophrenic and cardiophrenic angles are normal. Mediastinum appears normal. Visualized bones appear normal. Bilateral hemidiaphragm appear normal. Based on radiographic findings, diagnosis was given as aspiration or chemical pneumonia. Chemical pneumonitis has varied appearance on radiograph. The most common presentation is consolidation. Right lower lung fields are more prone to injury because of vertical orientation of right mainstem bronchus. Basal segments, middle lobe, and lingula are more commonly affected in erect patients. Posterior segment of upper lobes, superior segment of lower lobes are most commonly involved in recumbent patient. Coming to case 6, 30-year-old with history of fall, tenderness back, unable to walk, referred from orthopedics department for knee radiograph of right knee joint shows mild displaced wedge-shaped fracture of lateral tibial plateau. Bone density appears normal, alignment of rest of the bones is normal. Based on radiographic findings, diagnosis was given as Schatzker type 2 lateral tibial plateau fracture. There are 6 types of fractures according to Schatzker grading. Type 1 is undisplaced or less than 4 mm displacement of lateral tibial plateau fracture. Type 2 is more than 4 mm displacement of lateral tibial plateau fracture. Type 3 is pure depression of lateral tibial plateau. Type 4 is medial plateau fracture. Type 5 is both medial and lateral tibial plateau fractures. Type 6 is type 5 plus proximal shaft fracture. As the type increases, prognosis is poor. Untreated or inadequate treatment leads to accelerated osteoarthritis. Coming to case 7, 52-year male with chest swelling since 3 days with very previous history of TB. Referred from general medicine department for chest radiograph. Chest radiograph shows rotation to the right side, major airways appear normal. Prominent bronchovascular markings and reticular markings in bilateral lung fields. Homogeneous opacification in right lower zone with indistinct costophrenic angle and right hemidiaphragm, suggestive of pleural effusion. Mild cardiomegaly. Small cavitatory lesion in right upper zone with adjacent pleural thickening and fibrotics. Based on radiographic findings, diagnosis was given as pulmonary edema with pleural effusion and reactivation of tuberculosis. As we have already seen the findings of pulmonary edema, let's see the findings in pulmonary tuberculosis. Most common presentation in primary pulmonary tuberculosis is hilar and paratracheal lymphadenopathy, consolidation, and pleural effusion. In post-primary pulmonary tuberculosis, we can say consolidation or reticulonodular opacities, cavitation, pleural involvement in the form of thickening, effusion, or empyema. In miliary tuberculosis, multiple small miliary nodules are seen involving bilateral lung fields, diffuse involvement. It is because of hematogenous dissemination, and it can be seen with both primary and post-primary tuberculosis. Thank you.